Welcome to the Resilient Performance Podcast. I'm your host, Doug Kachigian, and today I'm joined by Dr. Antony Davies. Antony Davies is Associate Professor of Economics at Duquesne University. Dr. Davies authors monthly columns on economics and public policy for the Philadelphia Inquirer and U.S. News and World Report, and co-hosts Words and Numbers, a weekly podcast on economics and policy. He has written over 300 op-eds for, among others, The Wall Street Journal, Los Angeles Times, New York Daily News, Washington Post, and Huffington Post. In addition to his academic work, Dr. Davies was Associate Professor at the Moving Pictures Institute, Chief Financial Officer at Parabon Computation, founded several technology companies, and is co-founder and Chief Academic Officer at FreedomTrust, a nonprofit educational institution. Dr. Davies earned his B.S. in economics from Saint Vincent College and Ph.D. in economics from the State University of New York at Albany. The impetus for having Dr. Davies on the show is to further explore the relationship between reductionism, integration, and global thinking in a complex system. When I was in the military, I often wondered if tactical and technical competence could compensate for lack of strategic vision and clarity. In the consulting that my partners and I do with professional sports teams, we're typically brought in to audit the physical preparation, staff, and system. But what we often find is, regardless of the competence of the performance staff, there are typically organizational and structural issues that would preclude any progress in a physical preparation program. Similarly, as a healthcare provider, oftentimes I'm frustrated because I feel like the lowest hanging fruit in achieving positive outcomes with the patients I see is not necessarily the interaction that the patient and I have one-on-one, but again, some of the structural issues that are associated with the healthcare system. And I think that for a lot of people, the limiting factor in their progress isn't necessarily finding a particular medical provider, but having better access to quality healthcare. And that doesn't necessarily mean having a better health insurance policy, because oftentimes these health insurance policies, I think, promote the wrong kinds of incentives. And so that's kind of what Dr. Davies and I discuss is how can the healthcare system create better incentives for both medical providers and consumers of healthcare. And I think you guys are going to find this conversation interesting. It's obviously a very complex topic, and we certainly didn't come up with any answers, but as is always the case, I'm just trying to generate some more questions.
Antony, thank you so much for coming on. I've watched quite a few of your videos and read some of your work, and really appreciate some of your commentary about healthcare. So I wanted to begin by asking you about this whole idea of whether healthcare is fundamentally an individual right or a service, and even if that actually matters. So the popular narrative is that, when healthcare is regarded as an individual right, it will necessarily be more accessible and more affordable, particularly to the destitute. And the implication there is that to make this healthcare more accessible, it's going to require more government intervention, which I don't know if that's necessarily the right conclusion, even if you do believe that healthcare is fundamentally a right. But when we're attempting to increase the quality, accessibility, and even the affordability of healthcare, do you think that even attempting to differentiate between whether healthcare is a service or a right is actually meaningful?
Yeah, the question is interesting, and it has two answers, an economic answer and a philosophical answer, neither one of which is going to be happy, right? So the economic answer is, look, so long as it requires resources to provide health care, it's irrelevant whether you define it as a right or a service or a good or anything else. It doesn't change the underlying economics, which is to provide a certain quality and quantity of healthcare requires in turn the investment, the utilization of a certain amount of resources. So the economics is completely agnostic to what you call the thing. Philosophically, however, the matter is very different. We have a tendency in this country to talk about healthcare as a right, and we use the term in a very, how should I say, irresponsible manner. We use it almost as a synonym for desirable. So we say it would be desirable for everybody to have healthcare. And I have no qualms with that statement. Absolutely, it would be desirable for everyone to have healthcare. But to say that it's a right opens up a whole new can of worms, because if something is a right, then it means that the person has a right to this thing, and it is fitting and proper for government to step in and make sure that the person has the thing because the person has a right to it. So practically speaking, what does it mean? Well, if I and everyone like me has a right to health care, then that means that the government has carte blanche to tax us as much as it needs to provide health care for us, because it is our right. And if the government taxes us as much as it possibly can, and suppose we end up in a situation where, despite the government doing everything that is doing, there simply aren't enough physicians, there aren't enough nurses to provide the level of health care to which we claim we have a right, the government then has the ability to conscript people. That is to say, all right, you college student, you're studying engineering, no more. Now you're going to study nursing, or now you're going to study medicine, because we have to have more doctors to provide this right that we have defined for people. So we have to be extremely careful using this term right. It has all kinds of other philosophical implications.
Yeah, that's a really interesting answer. And I think that the distinction you made, which is really important, is that if you're looking at it or healthcare in economic terms, I don't think the political distinction or the philosophical distinction of whether you consider healthcare a right or a service is as meaningful, because ultimately you have to generate a concrete policy, which is where I think in economic analysis and the lens through which you look at healthcare is very important. And I think it can even be problematic to assume that if you regard healthcare philosophically as a right, that necessarily means that the government is the best vehicle to sort of maximize the accessibility to that right. And I think we're going to kind of, try to get to the bottom of how do we come up with a better concrete solution, regardless of where you lean politically and philosophically on the issue. But I think another important question to ask before we even get into those details is that health is a pretty complex construct. And I think we have to be able to determine, what metrics are indicative and suggestive of health before we can even evaluate a policy. And a lot of times you'll hear things like, well, in this country, life expectancy is higher than in the U.S., as if life expectancy is automatically and necessarily a good indicator of systemic healthcare. When I just feel like there's so many variables that could influence something like life expectancy. And as an economist, it's kind of your job to tease out. There's so much information and noise. What are the variables or the metrics that actually matter when we're measuring something like healthcare? Because a lot of times, as you know, people will cherry pick the metrics that support whatever side of the political aisle they lean towards, and there's no perfectly concrete way to answer this. But I guess, what do you think is a good way to start as far as what metrics are most indicative of sound healthcare systemically? Yeah.
The question, I think, gets the thing wrong. And don't get me wrong, this is a question that lots of people ask, and they ask it quite seriously. But I think the thing it gets wrong is that the question assumes that quality healthcare means the same thing to everyone. And it doesn't. People have very different needs. I may be perfectly fit, but have bad teeth. In that case, what I consider quality healthcare is something that's lots of dental work and light on everything else, right? Someone else might have a history of cancer in the family, and for that person, quality healthcare has nothing to do with gynecology and obstetrics. It has to do with oncology. And so what you find is there is no right metric for quality healthcare, because it necessarily varies depending on the individual you're dealing with. And herein lies the huge problem of doing something like turning to a government and asking it to manage healthcare. because governments are not designed to deal with people as individuals. They're designed to deal with people en masse. And so you'll get a one size fits no one, right? Rather than individual things. Now, having said all of that, there are some things we can point to that I wouldn't say are appropriate metrics for quality of healthcare, but they're at least indicators to indicate that maybe healthcare is getting better over time, or maybe it's getting worse over time. So these are very, very broad measures. One reasonable measure is the infant mortality rate, right? So what happens to our children who are born? And what you find is in the United States since the 1960s, the infant mortality rate has fallen almost 80%, 80, right, since 1960s. Deaths due to pneumonia, influenza, they've fallen almost 70%. I'm pausing as a truck goes by.
Okay.
Deaths due to heart disease are down almost 70%, right? So mortality, which is a relatively easy thing to measure, right? It's binary. You're either alive or you're not. Mortality measures are all pointing in the right direction. In fact, if we stick with mortality in general and ask the question, how many people would have died in the United States if our quality of healthcare remained at 1960s level? Or in other words, if we had from 1960 forward the same mortality rate that we had in the 1960s. So just hold that mortality rate constant. And what you find is that today, now, although we complain, and perhaps rightly so, about the rising cost of healthcare, if we had the same mortality rate in this country today that we had in 1960, there'd be over 250,000 Americans dying each year that aren't dying now. So when we look back on the 1950s, 1960s longingly, saying, well, look at how cheap healthcare was back then, we have to be very careful, because we're actually not being nostalgic for 1960s healthcare. We're being nostalgic for 1960s prices. That's a very different animal. If you ask the average American, would you rather have today's prices or 1960s prices? Of course, we'd rather have 1960s prices. But if you coupled that with, would you like 1960s prices at 1960s quality, or would you like 2017 prices at 2017 quality? I think what you'll find there is a large number of people saying, no, give me the high prices along with the high quality.
Yeah, and I think the point that you made that's really important is maybe it's not even the right question to ask what metrics are most suggestive of sound healthcare systemically, because, like you said, it varies on an individual basis. So if you're trying to maximize the quality of the product through medical education and technological innovation, and then you let kind of market forces dictate accessibility to that higher quality product, potentially the price is presumably more likely to be at that 1960s level compared to whatever it is now, because as you know, you've pointed out in some of your talks, the price keeps going up disproportionately relative to other services if you consider healthcare a service. So yeah. I know that you've talked about. Yeah, sorry, go ahead.
Yeah, it does. And I think, again, people get hung up on the price. Not to say that the price isn't important, but we have to keep it in context that yes, healthcare is tremendously expensive today, but on the flip side, you and I can walk into a Walmart and buy something over the counter that will cure a malady that 100 years ago people would die from. And that's a tremendous value. Give you an example, right? So Andrew Carnegie lived in whatever he lived, 1800s. He was worth, if you adjust for inflation, he was worth $320 billion. Now, put that in perspective. His wealth was the equivalent of Bill Gates, Jeff Bezos, Warren Buffett, Mark Zuckerberg, and 3 Richard Bransons all combined, right? This is an ungodly wealthy guy. He dies of pneumonia, right? Something that today a regular middle-class person can walk into a emergency room or a health clinic and get drugs to cure. You with me?
Yeah.
Okay.
I thought you were pausing for a second.
No.
Yeah, and then I think the next thing I want to talk about is we've sort of, at least in this country, conflated healthcare with health insurance and in turn employment. And I remember in one of the talks you gave, you spoke about historically kind of the evolution of how that came to be. But how is conflating all those different things problematic, do you think?
Now you'll start to get a hint here into my conclusion, right? And the question is, what is this linkage between employment and health insurance? And that linkage creates all sorts of problems. One of which is this pre-existing condition thing that you keep hearing about. Someone goes to get insurance and they're denied insurance because they have the pre-existing condition. Not in every case, but in many cases, that is the result of the person actually changing jobs. That, I worked for employer A, I had my health insurance through employer A, I switched to employer B, so I lose my previous health insurance. I now pick up a new health insurance, and this new health insurance provider looks at me and says, oh, you have a pre-existing condition, we're not going to cover you. The real problem there is not the pre-existing condition, it's the fact that I was forced to drop one health insurance provider and move to another one. And the reason I was forced to do that was because the insurance is provided through my employer. Now it's something we're just used to because that's the way it's done. But if you stop and think about it, it's weird, right? We don't get our car insurance or our life insurance or our home insurance through employers. Why do we get health insurance through employers? And the answer, interestingly, goes back to the 1940s, when around the time of World War II, the federal government was concerned about rising prices in this country, and in 1942, Congress passed a law prohibiting businesses from raising their wages. So if you're a business owner and you're looking to attract good talent for your business, normally the way you do that is by offering a higher wage, but according to this new law, you're not allowed to offer a higher wage. But in this law, Congress exempted employer-paid benefits. So what that means is, if I, in 1942, want to hire you away from your current employer, I can't offer you more money because of the wage cap. However, I can offer you employer-paid benefits. So I'll say, look, come work for me, and I'll pay for your health insurance. And so this was a way that businesses were attracting employees, and this is what started the whole ball rolling of employers providing health insurance. And then what happened some years down the road is Congress turned around and made that employer-paid health insurance untaxable. So now it's a matter of, in today's market, although there's no further wage cap, if you're offered by your employer the option between a $1,000 wage increase and a $1,000 increase in your insurance benefits. If you take the wage increase, you get $1,000, but you're going to pay 25% of that in taxes, so you actually walk away with $750. But if you get $1,000 more worth of health insurance, better benefits, you get that full $1,000 because that's not taxed. And so we've ended up in this very weird space where the whole reason that we have much of this pre-existing condition problem is because of restrictions that the government had placed on markets back in the 1940s.
Yeah, it's just so interesting how an arbitrary regulation 70 years ago could still be impacting healthcare. No one really questions, why have we come to equate healthcare with health insurance and employment? It's because something that happened in World War II. Right. But it has really profound implications for what's happening now, and I think it's contributed to some of the dysfunction. And part of that dysfunction is the lack of price transparency for medical service. So how do you think that the current healthcare system impacts price transparency, either in a positive or a negative way? Because it just seems like medicine is one of the few areas where we really can't shop around based on price. You can't just go to a hospital and say, what does this procedure cost? You just kind of assume, well, my insurance company is going to pay for it. But we don't do that anywhere else. So why is healthcare unique? And is it good that healthcare is unique in that regard, in your estimation?
And the interesting thing here is it's not healthcare that's unique. in this sense, when it comes to prices, healthcare behaves economically the same as any other good or service. What's unique are the laws that we've placed around it. So in that sense, its odd behavior isn't natural, it's artificial. And part of the reason it behaves this way is because, going back to this tax-free benefit thing, what's happened is over time, because health insurance benefits are tax-free, all of a sudden now, things that you would normally have paid for out of pocket, not actual things that you would imagine would be covered in insurance, things that are due to risk, but just normal health maintenance things, right? Like vitamins or, eyeglasses or something. All of that stuff starts, we workers start demanding to be thrown into insurance. We want broader and broader insurance coverage. Why? Because if I'm going to spend $10 on vitamins, if my employer gives me $10 cash, I walk away with $7.50 after taxes, and I only have $7.50 to spend on vitamins. But if the $10 comes through my insurance, now I can get $10 worth of vitamins, right? So I have an incentive to push to have as many things covered by insurance as possible. And so you now end up in a situation where you have no prices. And you have no prices because we have made almost the entirety of the healthcare industry the equivalent of an all-you-can-eat buffet. You pay a price to get in the door. That's the cost of your monthly fee for your health insurance. And then you consume whatever you want. And you're not paying attention to the prices because all of that payment for the stuff happens on the back end. In fact, I had a friend who called up and asked the local hospital what the price of an appendectomy would be. And they laughed at him. They had no idea how to answer the question.
They're not even going to know.
Right, yeah.
Yeah, so then, maybe going back to the abstract, you're basically suggesting that the current system incentivizes health insurance to pay for things that normally we wouldn't use insurance for. So if we're talking about like car insurance, you usually wait till you have some kind of a borderline catastrophic accident before your insurance pays for it. The insurance doesn't pay for tune-ups and oil changes and maintenance on the car, but that's effectively what healthcare pays for. So I think we have to get theoretical before we go back to policy. So in the abstract, what services do you think that health insurance should reasonably cover? Because I think this is an area where health insurance differs from other types of insurance that we use, whether it's life insurance or homeowners insurance or car insurance. And then, so I think that this ties to the fundamental question when it comes to healthcare policy, which is how do we, utilize the healthcare system to incentivize healthy behaviors while we also demonstrate compassion for people with things like genetic anomalies, unforeseeable circumstances, and emergent conditions. So at some point, possibly the government might have to intervene, but what do you think is a reasonable line to draw as far as what health insurance should actually cover when we consider some of those other variables?
Yeah, this sounds a lot similar to that first question, and my response would be I think we're asking the wrong question when we say what services should health insurance cover. The question implies that there is a correct answer that applies to everyone. And again, I don't think that's the case. It's like asking what channels a cable package should include. Well, depends. If you like sports, buy the sports package, right? If you want science fiction, you buy the science fiction channels. And you let each person purchase what is important to each person. I think it's a similar thing here. Now, there are all sorts of things we can talk about, like, well, shouldn't insurance cover, catastrophic illness? And I can say for myself, yeah, insurance should cover catastrophic illness, but I say that for myself. That is, I would buy insurance like that. You can imagine other people who maybe they're healthier, they don't anticipate, they live a very safe lifestyle, they don't think that they're going to need such a thing, or maybe they would much rather spend their money on something else rather than this insurance, and in turn they would say something different, right? So I don't think there's a right answer to what services should health insurance cover. Rather, it should be left up to, as every other product, up to the buyer. What is it that I particularly want at this point in time?
Right, but I think in the abstract, I would totally agree with that. But I feel like there's so much regulation when it comes to healthcare that there isn't enough competition to really maximize choice. Like, what choices do we really have when it comes to healthcare? People talk about catastrophic plans, but I feel like if there was less regulation, these catastrophic plans would be way less expensive than they currently are. And really, even when it comes to these health insurance companies, there aren't that many really that are competitive. So to what degree do you think that competition and really like stifles the choices that we actually have when it comes to selecting a plan that's most appropriate for us? Because I don't know if those plans are really available because of the regulation, but I could be wrong.
Right. And the whole question of competition is very interesting in the healthcare industry, because there are people who quite reasonably say, well, one of the major problems here is there's not enough competition. But the source of the lack of competition is actually government regulation. So those who say we need the government to intervene to give us more competition are getting it exactly backward. It's the government presence that is preventing the competition. Give you a couple of examples. Prior to the Affordable Care Act, it was kind of standard practice amongst many states to make it very difficult for out-of-state insurers to offer insurance to people who are in-state. So I'm in Pennsylvania, and Pennsylvania would have laws that would say if you're an insurance company in Utah, you may not sell insurance to people in Pennsylvania, or if you do, we're going to charge you a tremendous fee for doing that. And why does this law come about? Well, it comes about because insurance companies in Pennsylvania have a profit motive to lobby the state for exactly those laws, because it sets them up as a little fiefdom. They have their own local monopoly within the state of Pennsylvania. It keeps out competition. So these things like this, from that all the way down to, and this becomes much more dicey, but to an extent, we talk about FDA regulations, these sorts of things. Anytime you ask the government to come in and regulate an industry, you open a new door to profit for the firms that are in that industry. Prior to government, the only way a company can make a profit is by convincing you that its product is worth your money, and so that you voluntarily hand that money over. When the government comes in as a regulator, there's now a new way to make profit. That's to turn around to the government and co-opt the regulators and ask them for regulations that, in effect, keep out competition.
Right. And then I think another thing that might be contributing to this phenomenon is that the idea that a more or a less regulated healthcare system wouldn't be competitive with, or wouldn't be compatible with, any semblance of a welfare state. So in other words, these more market-driven healthcare solutions wouldn't protect the homeless person who might die in the street of a heart attack. And so I think that some people will say, well, if we have it's almost the idea that, like, just because you're not a socialist, that makes you an anarchist, right? Like, if you don't think the government should have its hand in the entirety of healthcare, you might still believe that there's a place for the government in covering like the 10% of the population that's really, really destitute or indigent. But it's these where we sort of like to portray one another as extremists, where if you think there should be a more market-driven solution, that automatically means that you're okay with the poor people not having any access to healthcare. And I think that you could either have a hybrid system where it's predominantly market driven, and then you allow some role for the government to cover the people who are have less resources available to pay for some of the more market driven plans, or you could even presumably have the free market cover the indigent. But what do you think the role is when it comes to, we have to have some semblance of a welfare state? Do you think it should be more, what should be the role of the government there, or should that also be more market-driven and less regulated? Or do you think it'll kind of sort itself out if we just deregulate the entirety of the system?
Yeah, I think it's important to keep in mind here that if you're having a high-level discussion about what health insurance should look like, it's disingenuous to turn around and say, well, but we should design the whole thing with specifically to meet the needs of a small percentage of the population. Here we're talking
Right.
about the poor, the indigent, which comprise, you said 10%. I think it's much less than that. But
Yeah.
nonetheless, it's kind of odd to say, okay, we're going to design this system for 320 million people with 10 million of them in mind. A much better solution is to design the system for the 320 million and then turn around to the 10 million and say, okay, there's a separate issue here. It's not health insurance, which we just addressed over here for the 320 million. It's poverty. Let's deal with
Right.
that. And you see some interesting examples of this that actually do work out quite nicely. We're concerned in this country that everyone have enough to eat. The way we did not address this is by having the government set up a system of farms and food distribution networks and government grocery stores to make sure that everyone has enough to eat. Instead, what we did is we said, okay, private sector, you handle the growing of the food, the transporting of the food, the selling of the food in the grocery stores, because that's what you do well. I, the government, will tax people and hand out food stamps to the poor. And with these food stamps, the poor can take them and go buy whatever they want at whatever grocery store they want. And so there you have a very nice hybrid solution of markets and government. Markets doing what they do best, bringing the quality and price that people are looking for to the market as a whole, and government doing what it does best, which is saying, okay, we need to take care of this small number of people. The way we're going to do it is to tax the large body of people and hand this money to the small body of people and let them go and do their thing. I could easily see us handling health insurance the exact same way.
Yeah, I think you really emphasize the importance of nuance there, and a lot of times we'll look at a very small segment of the population and say, well, the healthcare system has to, because we have to address this very small subset of the population, that whatever solution that we find for that small subset has to be applied to the rest of the population, which is kind of a very, I don't know how you can necessarily make that conclusion, but there's always, very rarely, even in the most extreme types of societies, do you have a purely government-driven socialist system or a purely driven market system. It's always some kind of a hybrid. And the real discussion is, what are the reasonable boundaries, which is what you're attempting to draw here. But a lot of times, again, we like to label one another as extremists when really it's just trying to really find this muddy middle area that isn't really in the middle. It might shift left or right, but I think there are these hybrid solutions, and when you try to look at things through only one lens, it can be problematic. And I want to kind of tie that into another really timeless philosophical question, which is at the heart of what we're talking about here, where how do you think a more market-driven healthcare system can serve the indigent while also simultaneously incentivizing that, people near a predetermined poverty line to actively seek their own care? Because let's just say arbitrarily that if you make $20,000 a year or less, you qualify for all these government subsidies or government-funded healthcare initiatives. These healthcare initiatives could be worth tens of thousands of dollars. So in some ways, you're better off, making $19,000 as opposed to $25,000 because you're getting all these additional benefits. So again, it's kind of a timeless conversation, but how do you think that we go about answering that question, at least as it pertains to healthcare? Because that's what we're talking about right now.
Right. So this is one of the instances in which you have to be very careful how you craft the regulations. There's an economist, Clifford Thies, who did a study along these lines. He was not asking about healthcare, but he was asking about welfare benefits in general. And he took a hypothetical family of three living in the state of Virginia and imagined that this family the household earned $10,000. And so he calculated how much they'd pay in taxes and how much they would receive in terms of income supplements, housing subsidies, right? Help with the electric, all these sorts of programs that the government does, the food stamps, all of this. And so he figured out the dollar value of what they have at the end, which of course is significantly more than $10,000. And then he did an interesting thing. He said, what happens to this family as they start to earn more money, as they go from an income of $10,000 to $20,000 to $30,000 to $40,000? And what he found was appalling. there's an unintended but very real interaction of all of these various individual government regulatory programs, such that if this family of three is earning $20,000, it's actually worse off if it attempts to earn more. So in his case, if they're currently earning $20,000, they get so many benefits for low income benefits, and if they increase their income to $30,000, some of these benefits start to shut down. And in fact, enough of them shut down that they actually lose more than $10,000 in benefits. They're actually worse off at the end. And this is your audience, being medical people, will understand this perhaps even better than I. That you have to be very careful of this with drugs. That you don't wantonly prescribe drugs for a patient without knowing what other drugs the patient is already taking because of interactions. That same exact dynamic goes on with regulations. And so we write one regulation to handle food stamps, and we write it a certain way, completely oblivious to the fact that there are other regulations involving, housing subsidies and unemployment insurance and all of this that will interact with this to cause bad results to come out. So that's a very long-winded way of saying that if you're going to have the government interfere in some fashion in health insurance, it has to be as absolutely simple as possible to make sure that you have the minimum number of these negative interactions.
No, I don't even think what you said was long-winded. I mean, it's such a fascinating question as to where do you draw these boundaries? Because like you alluded to, there's so many unintended consequences. And I guess the answer to the question really is contingent upon what people fundamentally value from an ethical standpoint. Because I think it comes down to basically, if the system goes awry, what are you more okay with? Are you more okay with people kind of mooching off the government, or are you more okay with drawing the boundary in a different direction where people who legitimately need government service and are sincere and aren't trying to take advantage of these services are going to be without access to some of these services? So, I guess it sort of depends on how compassionate you are and what you're okay with people getting away with or not getting away with. But ultimately, there's a downside to where you draw the boundary, regardless of what your ideological leanings are. And that's why I think these conversations are really timeless and ongoing, because we're never going to totally nail down, where's the perfect boundary? What is this poverty line upon which all these services should be offered by the government to people? I think it's really more of a sliding scale we have to constantly reevaluate. And I think there are a lot of really bright, well-intentioned people who, just because by virtue of the complexity of this question, haven't really come up with a great answer. And that's why it's a really timeless discussion, and why I shy away from people who are very, very definitive about I have the solution to this problem, because there's really no great solution. It's kind of like, what's the least worst? And then how do you continue to reevaluate it over time? So right. Moving on, the next thing I want to talk about a little bit is we assume that the healthcare system kind of works in a vacuum. And as far as like health insurance goes, that it's all these, whether it's the insurance companies or the government, that are kind of dictating how healthcare is offered as a product. But I think that healthcare providers are also, if you don't like the current system, I think healthcare providers are somewhat complicit in the product that we have now. So to what degree do you think medical professionals themselves are complicit in overly regulating healthcare and minimizing consumer choice? In other words, I think that for some, there's a lot of infighting amongst different professions who offer comparable services, and different professions lobbying for licensing requirements or scope of practice restrictions to limit supply. And I think that there should definitely be practice standards that people, kind of like what the FAA does and not everybody should be allowed to be a pilot, right? Not everybody should be allowed to be a surgeon. I think that when it comes to some of these specialized disciplines, there probably should be a little bit more regulation and higher standards. But at least when it comes to primary care, which is a huge part of some of these healthcare expenditures, I don't necessarily know if physicians are the only ones who can treat people, for example, with type 2 diabetes or heart disease, if they're necessarily any better at it than physician's assistants or nurse practitioners. But obviously all these professions have a stake in being the initial triage point, and that whatever profession I think has the highest market share at this time and the most powerful lobby, to be honest, is trying to to protect that turf. So how do you think that medical providers could do a better job of creating more options for the consumer, albeit in a responsible way?
So this is a hard question because I can understand both sides of it, right?
Sure.
As a medical professional, clearly you have a vested interest in your profession augmenting, right? If I'm a medical doctor, I'm not going to look kindly on some newfangled degree that isn't a medical doctor being allowed to write prescriptions, right? That's going to take business away from me. So on the one hand, that's quite understandable. On the other hand, we have to realize that yes, there are safety concerns, but there's also a turf concern going on, and the safety concerns should be paramount, but the turf concerns not so much. And this takes the form not only of some professions trying to keep out competition, but it also takes the form of the professional organizations lobbying the states for special treatment. So I give you an example. I have some figures for the cost, the average annual premium for individual health insurance. So this is not through an employer. This is just what you would pay for yourself. And this was just prior to the Affordable Care Act, right? And if you look across the states, you have a high in Massachusetts of over $5,000 per year, the annual premium, down to a low in Alabama of under $2,000. And the median is somewhere around $2,500 a year. But it's this huge difference between the high-cost states and the low-cost states. And there are all kinds of things that feed into that. But one factor that does feed into it is the number of insurance mandates. That is, within a state, the state can pass a law saying if you insurance company are going to sell insurance in this state, your insurance must cover the following things, and just list out a whole bunch of things your insurance has to cover. Well, it turns out that the states that required more of those mandates, more things to be covered by insurance, end up on the higher end of the cost scale. The states that had fewer mandates ended up on the lower end of the cost scale. And what's going on is the same sort of effect you would get if, for example, your state said, all right, if you want to sell a car in this state, it must have a top-of-the-line stereo, leather seats, sunroof, anti-lock brakes, the backup camera thing, all of that stuff. If it doesn't have all that stuff, you may not sell it in this state. Well, so what happens? What happens is you've got really nice cars in this state, but you've just shut out of the market all the poor people who can't afford a car like that, and they don't need all that stuff. They just want to get from point A to point B, for God's sake, right? And you've shut them out of the market. And then, on top of everything else, these cars are expensive to produce, so the price is high. And now people look at this and say, well, look at this high price of insurance. The government should do something about that. Well, the government was the cause of it. And it came
Right.
about. It came about because of this term I used earlier, co-opting. What happens is the regulators in the government, they aren't industry specialists. They're not medical doctors by and large. They don't know this industry. So when they're writing regulations to regulate the healthcare industry, who do they turn to? They turn to experts. Well, who are the experts? They're the people who are being regulated. And the people who are being regulated now have the opportunity to give advice for regulations that actually benefit them, as opposed to benefiting society as a whole.
Yeah, it's fascinating because I'm a physical therapist, and physical therapy over the last couple of years has become a much more autonomous profession. You don't need a referral in most states to see one. So they've effectively become primary care musculoskeletal providers, at least in an outpatient environment. And that they had to fight really hard to get that. But what's also interesting is that the way that the medical diagnosis system works, I mean, there's definitely a financial incentive to pathologizing things that might not really matter that much. So not to trivialize people's experiences, but at least in my field, outside of like a post-surgical case, in an outpatient physical therapy scenario, people are coming with like atraumatic knee pain, non-specific low back pain. And if your insurance company is reimbursing you for the visits, the insurance company will say, well, you're authorized 3 visits a week for 8 weeks for your non-specific low back pain. But in non-specific low back pain, there isn't always a linear cause and effect between tissue pathology or what somebody might find on an MRI and the clinical presentation. So a lot of the stuff, especially when it comes to these atraumatic type of musculoskeletal symptoms, it's really more about just education and exercise and good lifestyle habits that you can really teach somebody in like 2 or 3 sessions total. And then as long as they comply with what you told them, they shouldn't really have to come in 3 times a week for 6 to 8 weeks. But if you're that medical provider, because I actually don't, I'm all out of network insurance because I feel like I wouldn't be able to practice in the manner that I think is most effective if, I was being reimbursed by an insurance company, because I'd have to have more of a volume-based model and not as much of a quality-based model. But the idea is if you are taking insurance, at least in my field, you really don't have a lot of incentive to discharge somebody before those 18 visits, because it's a gravy train. You're getting paid no matter what. And then if you're the patient, you're kind of like, well, do I really have to do that? Which, I mean, if I went to the dentist, for example, and the dentist said, you've got to come in 3 times a week for the next 6 weeks, I'd be like, you're out of your mind. I'll brush my teeth and floss at home, but I'm not. Right. But some people, I guess, with physical therapy, we've conditioned the public to believe that they need that kind of frequency. But a lot of that frequency is contingent upon diagnoses where we're convincing people that they have all this pathology when they really don't. It's really more of like a movement-related issue or a lifestyle issue, or even just getting people to move in a novel way and build them back up. So it's really interesting how all these things tie together. It's the insurance with the direct access and increased autonomy. But I always wonder, and this is another philosophical question, if you're a medical provider, is your duty to advocate for your profession, or is it to advocate for medicine as a whole? And I think that a lot of times those two things can be at odds, because if you're really advocating for the patient, you should actually want more cooperation and more choice. But I mean, I get the politics that are involved in it, but it can be kind of frustrating because there's a lot of tribalism in medicine that I think the patient or the customer ultimately suffers. So do you have any thoughts on that as far as some of your experiences with the medical system?
Well, I have a friend of mine who's going in for eye treatment, and I'm just going to repeat kind of words I've heard. Apparently, there are 2 different treatments for this thing, and one is relatively cheap, on the order of low hundreds of dollars, and the other one is incredibly expensive, on the order of multi-thousands of dollars. This is per treatment. So he goes in, I don't know what, every month or 6 weeks or something. And so over the course of time, this one drug is tremendously expensive. The other one, not so much. So which one is the doctor prescribing? Well, the doctor's prescribing the one that's multi-tens of thousands of dollars. Why? Well, because apparently it's supposed to perform slightly better than the other one. But more importantly, because insurance is covering all of this, it doesn't matter to the patient.
Right.
And that's a really weird thing, because anywhere else where you're talking about purchasing some service, always you have to weigh the benefit that I'm getting against the cost. And we have this tendency when it comes to healthcare to say things like, well, the cost shouldn't matter. Economically, that's a completely nonsensical statement. It's nonsensical because the service you're providing doesn't arrive out of thin air. It requires resources. It requires society's resources to produce this thing, which means there is a cost associated with it. It may not be comfortable to talk about it, but that doesn't mean it's not there. And so if there's a cost associated with it, there is necessarily the question of the trade-off. Is this slightly better drug worth an extra couple of zeros on the price tag? That kind of calculus goes on when we see a price in front of us and we decide, okay, I'm going to pay this. I've got to decide, do I want the more? Do I want the less? But when we have insurance cover it, that thought process doesn't go through anybody's head. So everybody, from the patient to the doctor, says, yeah, fine, get the expensive stuff. And who ends up paying for it is everybody else in the form of higher insurance premiums.
Well, yeah, and then I think the assumption is that, well, it's free, so who cares? But is it really free? In other words, let's assume for a second that you're getting $10,000 a year in health insurance benefits from your employer. if you had a system that fostered more competition and price transparency, would you be better off with that $10,000 in your pocket, and now you could buy a plan that's presumably more affordable and then do whatever you wanted with the rest of the money? And I think that's the thing people don't get when it comes to health insurance. They assume that, well, like, I'm not really paying for it, but you kind of are. So, I mean, how do we do that kind of like cost benefit analysis when it comes to, even on an individual level, like if you're trying to decide who to vote for, and healthcare or health insurance is a big part of a big driver for how you're going to vote. How do you evaluate these kind of things? Because I think a lot of times these discussions are very superficial, and the assumption again is that, well, it's free, it doesn't matter. But is it really free? I mean, what's the cost to basically having your employer provide you with $10,000 in healthcare benefits versus you see what happens with like
sorry,
even with like LASIK, like even with LASIK surgery, right? I mean, that's generally not covered by insurance companies, and it's gotten a lot cheaper over the years. So I mean, I know I tuned out for a second. Do you kind of get the fundamental gist of the question? Where is it really free? In other words,
that word free is causes no end of grief to modern economists, because you hear it constantly from politicians. We should have free healthcare, or we should have free education, or what have you. Nothing, absolutely nothing is free. When we talk about things like free healthcare, free education, what we really mean is making somebody else pay for the thing that you're getting. So, the guy who goes in and gets his whatever kind of eye care he's getting, and he walks away saying, well, that's great, that was free, I didn't have to pay anything. No, his neighbors and his parents and his children eventually, and his coworkers, they had to pay for it. And the perverse thing is, they don't get any say in whether he gets the more expensive treatment or the less expensive treatment, but they're required to foot the bill nonetheless.
Yeah, and that's the thing, even as a voter, I mean, I'm okay with having some of my tax dollars subsidize care for someone who's been dealt a really bad hand, but I don't know if I'm okay with it for someone who's making as much money as me, paying for that person's government associated healthcare policy, paying for that person to get acupuncture treatments. But that's effectively what's kind of happening now with the lack of competition. So again, it comes down to, like, where do you draw these boundaries? But it's very rare that people have discussions about the boundaries, because the way that even post-ACA, the way that healthcare progress is portrayed, it's like, well, more health insurance, more Americans have health insurance than ever had before. Well, that's because it's illegal not to have it now. Does that mean that that's a measure of progress? So we don't really know how to evaluate progress when it comes to some of this stuff, because it's really hard to be an expert in everything. But I think people with their sound bites kind of take advantage of that. So I mean, how do you think we can go about being better informed consumers when it comes to all this information? I think economists are actually the best equipped people to do it, which is why I like talking to you guys.
What the best thing that I can say when people ask me questions like this is we have to stop imagining government as a magic wand. And we do this all the time. We see a problem and we say, well, the government should fix that. Honestly, as if it were a magic wand that you pick up and wave it around and the thing disappears. It doesn't work that way. When you ask the government to regulate something, to do something, it brings not only, along with whatever it is it's doing, all its inherent costs of being a big bureaucracy, but in requiring people to behave certain ways through regulations or restrictions or what have you, it creates unintended consequences. And so it causes people to start behaving in ways that the government never anticipated, never intended, because they're trying to do the best they can around these new restrictions that have been placed on them. I think the thing to keep in mind here is that government suffers, well, everybody suffers, but it's particularly pronounced with government, from what economists call the knowledge problem. And the knowledge problem says that the government regulators, even if, let's take for granted that they are well-meaning people, they simply don't have enough information to be able to make the decisions that they're trying to make. And give you an example. Imagine that you were asked to decide what a room full of 30 people are going to have for lunch, right? You don't know who has what dietary restrictions. You don't know who had what for breakfast and wants something different for lunch, and who likes pickles and who doesn't, and all of this. And so if I ask you to make decisions, who's going to, what are we going to have for lunch? You're going to make decisions wrong for a lot of people. Now multiply that by 100 million. Right. And now and something not as simple as a sandwich, but something as complex as health insurance. And you start to see the problem. The government simply doesn't have enough information to be able to make these decisions well. So what's the answer? The answer is, to the extent possible, and this goes back to our discussion of the hybrid of government markets, to the extent possible, you let individuals make their own decisions, right? So you let individual states decide, with the only restriction being you can't block people from coming in and out of your state, right? Like they used to do with the insurance companies. You let states make their own decisions as to what healthcare should look like in those states. You let individual insurance companies make decisions. You let the individuals make decisions. You want to buy health insurance or not buy health insurance, or buy a lot or buy a little. It's up to you. Whatever you want to do, you just go make the decision between you and your insurance company. And what'll happen when you do this? You'll get a lot of people making wrong decisions, just the same way that the government did. The difference is you'll also have a lot of people who, either because of skill or intelligence or random chance, make good decisions. And the people who are making the bad decisions will see the others who are making good decisions and learn from them. And so you become, rather than one solution imposed on everyone, you become 50 or preferably 100 or 1,000 different attempts at solutions, until we can figure out which ones work the best for which sorts of people. And that's the joy of a competitive market environment.
Yeah, and what you're saying really speaks to the fact that a lot of disciplines are really trying to solve the same problems. It's really about embracing uncertainty. So in medicine, for example, I think that, we always like to think of things as very concrete and very linear cause and effect, but there's so much stuff in medicine that we don't understand. And kind of, at least my default and my bias is that if you don't really understand something, your default should be less treatment, not more. And in the political realm where it's healthcare, if you don't really understand it, it should be less regulation, not more. I think there's a cost of intervening when you don't understand all of the different forces involved. Like, I was in the military before I switched over to medicine. I've been to Iraq and Afghanistan, and regardless of what you think of those countries, like, we really don't understand the cultural dynamics of those two places. Right. And when you don't understand, there's a cost to intervening. And I think that's kind of where I wanted to end the discussion here, because it's kind of the same thing with healthcare. We can have this very abstract discussion where we could say, well, it would be better if we had less regulation and more competition and more emergent markets in healthcare. But as it is now, and I think this transcends politics, because it's not like Republicans are really advocating for the kind of system that we're advocating either. Maybe they want less regulation than what the ACA calls for, but it's still probably more regulation than you or I would think is appropriate. But so is the system now kind of like with Iraq and Afghanistan? We could say, well, if only we'd done it this way. But now it's kind of like it's so screwed up that we can't just leave and start over. And with healthcare, are we at a point now where, even though we're speaking the abstract, are we so dysfunctional that, like, is it even possible to transition to a system that we're advocating, especially in the short term, without disastrous consequences and chaos, at least during that transitional period? What do you think? I mean, where do we go from here?
I'm somewhat optimistic. What I'm going to tell you, it applies not just to the problems with healthcare in this country, but also to similar problems with Social Security, with public education, and so forth. We've reached a point in our history where the federal government is controlling so many things to such an extent that things are starting to fall apart. And by fall apart, maybe that's a bit extreme. They're not working nearly as well as we perceive they could be working. And I think what's going to happen in all of these cases is we're going to start to see a swing of the pendulum in the other direction, where the federal government starts to step back and let the individual states govern more in exchange for the federal government governing less. And what we're going to have is a march back, at least in the direction of where the country was originally founded, a conglomerate of 50 experiments in governing rather than one experiment.
Yeah, going back to the 1850s, right? Like everything is cyclical.
Understand, there's all kinds of problems that were associated there when the pendulum was too far in the other direction, right? I'm suggesting that we've gone too far in the centralized direction, and this goes back to your original, our earlier discussion of the mix of government and markets. There's some right mix there. Similarly, there's some right mix of federal versus state governing. And we got it wrong earlier, and I think we're getting it wrong in the other direction now.
Yeah, I just think the fascinating question is, I think a lot of people would agree that the current system is dysfunctional, but in the abstract, it's like, are we able to transition to a system that we think makes more sense when the deck is really stacked against it, just because of all the decisions that we made over the past couple of decades, starting in World War II with these arbitrary regulations. So I mean, it'll obviously play out like it always does, and we could keep having these discussions. But I think they're important to have, and certainly we didn't come up with the answers. The idea is just to kind of raise some of the pertinent questions. So I want to end with giving you a chance to just talk about what you're doing professionally at this point and where people can learn more about you, because you're working on quite a few interesting things and have your own educational platform. So if you could just share that with the audience, that would be great.
Yes, my colleague James Harrigan and I actually travel the country lecturing on economics and political theory to high school students, and so that's kind of what we do on the side. We're both he's at Utah State and I'm at Duquesne University. We have a weekly podcast, Words and Numbers. You can find us at wordsandnumbers.org, where every Wednesday we talk about economics and politics as it relates to the issues of the day.
Very cool. And then are you on any of the social media platforms?
Oh, you can find us on Twitter. I'm at Antony Davies there. You can find me at antonydavies.org, my website. So, if you're of a mind, drop me a note and be happy to continue the conversation.
All right. Well, really fascinating discussion. Thank you so much for your insight, and really appreciate your time, and have a great night. This was a good time.
My pleasure. Thanks for having me.